We are going to be discussing the pros and cons of restraints and seclusions in this debate. On the pro side, we have myself, Caitlin, Fresha, and Kelsey. On the con side, we have Oceana and Corinne. So let's get started with this debate and discuss what restraints and seclusions are. Restraint is defined as a measure or condition that keeps someone or something under control or within limits. Seclusion is defined as the act of placing or keeping someone away from other people. Here we have some examples of restraints. There's the prone restraint, which involves an individual lying in a face-down position. As you can see, there's a picture of a prone hold in the bottom corner. And then we have the supine restraint, which is an individual is lying in the face-up position, which is in the top corner. And then there is the ring, which involves an individual standing and their arms are restricted behind the back by two qualified professionals. Now we are going to hear Corinne discuss client safety for the con side.
Thank you, Caitlin. The Department of Education conducted a study proving information on the use of restraints and seclusion nationwide. This study found that nearly 700,000 students covered by the Individuals with Disabilities Education Act were restrained or secluded in 2013 and 14 when the data was collected. 200,000 of these students were found to have been restrained or secluded at least 3 times. This shows that 1 in every 100 students with disabilities have been restrained or secluded. Another study, which was conducted by the Harvard Center for Risk Analysis, estimated that 50 to 150 deaths occur each year due to the improper use of restraints and seclusion. This research also found that 8 to 10 children die each year from the use of seclusion and restraints. This side of our debate is against the use of seclusion and restraints. We are evaluating how these things are happening as much at such an alarming rate. Next, we will show a video clip from a video from the National Autism Association. This video in its entirety tells the story of how 4 families were impacted by the use of restraints and seclusion on their children. I would encourage that any individual in this field considering the implementation of restraints or seclusion watch this video entirely. For the purpose of this debate, we are going to follow Jonathan's story. Jonathan was a boy who was diagnosed at 18 months old with severe mental retardation, and at age 6 was diagnosed with autism spectrum disorder. Jonathan's parents chose to place him at a school and residential setting for children with ASD and other intellectual disabilities. Let's take a look at his story. Jonathan's parents made a decision to bring him home. He lived there with his parents for another year. At that time, another program had an opening. His parents described their placement as an attempt to gain trust back within the system for their son. But the misuse of restraints and seclusion was not an isolated incident to just one place, and their story continued. Jonathan lost his life in that restraint. His behavior was taking off his seatbelt and standing up in the vehicle while it was parked and another person was inside the bank. He moved from the back row to the row behind the driver and began loudly vocalizing. In court, his behavior was defined as disruptive. Would this be considered an emergent situation? I assure you that this is not an isolated incident. 8 to 10 children die each year due to these restrictive measures. Next, we'll talk to Kelsey.
Thank you.
Although you do make valid points, one of the main things to consider for pro restraints is the use of proper versus improper restraints and how this does play a role. With proper training and implementation, restraints can be beneficial, and it's actually a lack of training that results in safety risks. One of the main things, especially here in Florida, is safety care and PCM. Each state has their own set of standards and training, but I'm specifically going to talk about safety care right now. It's a program that provides the skills and competencies necessary to effectively prevent, minimize, and manage behavioral challenges with dignity, safety, and the possibility of change. Under safety care, staff is required to recertify yearly so that they're continuously trained properly, and they must document each time a safety care procedure is used. The core principles of safety care are its respectful, humane, and non-coercive interventions. Its main emphasis is on prevention over management. It used evidence-based procedures, and while the course material avoids jargon and is designed to be taught and used in a variety of contexts, the protocols in safety care are based on procedures that have been validated in many studies as broadly effective. These include basic applications of functional assessment, differential reinforcement, antecedent management, functional communication training, and behavioral momentum. One of the huge things that's embedded throughout the course is positive reinforcement, which is always your first option. Effective staff training requires an evidence-based approach, and a least restrictive approach requires options. Staff learns a series of interventions that can be flexibly adapted to the specific circumstances in which they find themselves. So whenever an agitated individual demonstrates a decrease in agitation, staff will learn to shape and reinforce that decrease by moving to a least restrictive intervention. Physical procedures are designed to be simple, effective, safe, and have minimal abuse potential. Restraint must be used only when there are no other safe options, and they must end as quickly as possible. These consistent standards reduce risk. They also train individuals to understand how and why crisis events happen and ways in which we might contribute to them without even knowing. We can prevent crisis using a variety of supportive interaction strategies. It teaches us to apply simple, evidence-based de-escalation strategies that are effective for any population. It also teaches individuals to respond appropriately and safely to dangerous behavior and to try and prevent the need for restraint if possible. So in conclusion, with proper training, restraints can be effective in ensuring safety as well as decreasing problem behaviors. So now we'll talk about client safety for the pro side. Restraints should be used always in the best interest of the client. And if it is necessary to keep a client safe, restraints will be implemented. Some of the instances where this might be used is aggression towards other clients or other individuals around, if there's self-injurious behaviors, and only to be used when the magnitude of these behaviors are high and if replacement behaviors are not yet in place. So now we will hear from the con side. No, we're not. Here's the graph to support rates of property destruction and self-injurious behaviors. It shows obviously an upward trend in the rate of these behaviors. And then once prone was implemented, it shows a dramatic downward trend. Prone, again, just to reiterify that, is where a client is laying face down. And it is a hold used only for their safety or the safety of others. And this shows its effectiveness. Now to the con side.
Thanks for that, Kelsey. I definitely agree on the importance of keeping our clients and ourselves safe at all times. And I also understand that when we're dealing with clients that frequently engage in severe aggression or self-injury, that it may seem like restraining the individual may be the quickest way to ensure that safety. Seclusion may also seem like an effective strategy to keep others safe during a severe behavior, but there are many alternative strategies to address these behaviors and generalized responses. In ABA, we generally strive to effectively teach skills that will generalize across settings, stimuli, and time. And I believe that it's more likely that we will get that generalized response if we're using the time that we have with our clients to teach them an applicable skill instead of following each problem behavior with a restraint or secluding the client. And once a restraint has been used, there's no longer an opportunity to teach a more appropriate response or a replacement behavior. Generalization can be achieved regarding these behaviors by using a variety of different intervention strategies, which can ultimately eliminate the need for restraints and seclusions altogether. And then when we consider self-injury, a differential reinforcement of other behaviors that could be implemented, and it actually has been proven in studies that they are effective. In fact, in 1994, Brian Iwata, Michael Dorsey, Keith Slipher, Kenneth Bowman, and Jenna Richmond conducted a function analysis on self-injurious behaviors. And the article was titled "The Allude to the Use of a DRO on Self-Injury." And in that article, they study 6 different clients, and all of their behaviors decreased in frequency and magnitude once a DRO was implemented. And then when we consider aggression, I personally suggest determining the underlying function of the behavior instead of relying on a reactive measure or using a physical restraint as a temporary means to address the behavior. Delays in speech and language are identifying factors of autism spectrum disorders, which means it's very likely that an aggressive behavior may function as communication for a specific client. If the client is trying to communicate a want or need, or if they're trying to communicate that they don't want to do something or they want to get away from a person, an activity, something aversive, then they may resort to aggression in order to communicate their needs. They also might use this as a form of communication just to show you that they want your attention. And in these cases, nonverbal clients that may resort to aggression as a means for communication could be introduced to alternative and augmentative forms of communication like PECS or Proliquo to Go, which is an application that produces a computerized voice for an individual that is nonverbal or has limited verbal skills. And by implementing these strategies, we can increase an individual's functional communication and decrease problem behaviors. So as I stated earlier, there's a lot of variety of alternative measures to address both self-injury and aggressive behaviors. And if you are using those interventions correctly and decreasing those behaviors, then restraints and seclusions truly are not really necessary. Caitlin, what is your stance on the use of restraints and seclusions?
Thank you, Oshi. In some instances with our clients, positive reinforcement itself just is not enough. The client's maladaptive behavior may not be decreasing with the use of positive reinforcement, so something else needs to be done in order to decrease this behavior. In these situations, you can implement punishment procedures with restrictions while also using positive reinforcement. That way, when you're putting the unwanted behaviors on extinction, you are also reinforcing the alternative behavior that is the same function as the maladaptive behavior. When introducing punishment procedures, it is important to remember the Ethical Code 4.08. This code discusses considerations regarding punishment procedures. In this code, it states that behavior analysts are recommended, when they recommend reinforcement, they need to recommend reinforcement rather than punishment whenever possible. Also, if punishment procedures are necessary, behavior analysts should always include reinforcement procedures for alternative behavior in the behavior change program. It then goes on to state that before implementing these punishment-based procedures, behavior analysts need to ensure that appropriate steps have been taken to implement reinforcement-based procedures unless the severity or dangerousness of the behavior necessitates immediate use of aversive procedures. Behavior analysts also need to ensure that aversive procedures are accompanied by an increased level of training, supervision, and oversight. These analysts must evaluate the effectiveness of aversive procedures in a timely manner and modify the behavior change program if it is ineffective. Behavior analysts always need a plan to discontinue the use of aversive procedures when no longer needed. And as discussed earlier, when positive reinforcement is used and no progress has been made, an aversive intervention may need to be implemented. There is a real-life example of a situation in which an aversion intervention was implemented to help decrease a client's biting. In this situation, the prone hold ended up being the intervention that was successful in decreasing the client's biting. It was used anytime the learner engaged in biting behavior, so biting objects, biting other people, biting himself. So let's take a look at this graph that shows the progress and the steps the BCBA took in order to decrease this client's biting behavior. As you can see, the BCBA used the client's PECS book, or Picture Exchange Communication System, as well as his iPad, which had Proloquo, as a proactive strategy to decrease the biting. However, as you can see, the biting remained at a high percentage. Then the BCBA decided to switch to the ring, which is also a restraint procedure, and the biting decreased, however, not significantly. The BCBA then decided to try a seclusion intervention, which at this center is called the focus room. With this procedure, the client got transported into the room by two therapists and put into the focus room. This focus room was a padded room that gives the client no access to other people or attention. However, there is a camera inside that allows the therapists and the BCBAs to observe the client. In order for this client to be released from the focus room, the client had to be calm for a duration of 30 seconds, as well as comply with a demand without engaging in maladaptive behaviors. Then the prone was implemented, and as you can see, the prone shows the decreased of biting, and it was the most successful. So overall, this graph shows the success and effectiveness of using aversive interventions to decrease aggressive behaviors in situations in which positive reinforcement does not work. Now back to you, Oshi.
Thanks, KB. You have made some really good points. And under the condition that perhaps a DRO, positive reinforcement, or functional communication training have all failed to produce a change in problem behavior, then the use of restraints and seclusions may be necessary to decrease that behavior. But I would only recommend implementing these if the behavior was truly a risk to the safety of others and the client, and all other intervention strategies have been attempted first. Even then, when implementing a restraint for an aversion intervention, it's extremely important to use the least restrictive procedure possible. So looking at your graph, seeing that the behavior was decreasing using seclusion and the ring, I don't know why that wasn't continued to be implemented rather than going into a more intrusive procedure, rather than waiting out that first intervention and seeing if the behavior would have decreased even more. And then when we do use these procedures, we definitely want to make sure that we consider a balance between the magnitude of the behavior and the magnitude of force in the restraint that we use. These two should definitely be equal, and a client should never be overpowered or receive an extensive restraint for a mild behavior. The same holds true for using seclusion, which may be used to address severely aggressive behaviors that are maintained by positive and negative attention. So if you wanted to use an empty space to seclude a client, the magnitude of the behavior that was occurring or the behavior that's occurring in the moment should definitely be considered when you're determining how long that client will be secluded from others. We want all of these factors to be taken into careful consideration and be balanced as equally as we can to ensure that we're taking the most ethical standpoint when using these procedures, and we want to keep our clients safe. Also, if restraints or seclusions are going to be used with a client, it should be faded and replaced with a less intrusive intervention as soon as possible. Now, Fresha will speak more on the language and stigma regarding restraints.
Thank you, Oceana, for that information. Although I understand your points against restraints and seclusion as a representative to the pro side, I would like to talk a little more in depth about the meaning of restraints and seclusion. The reason why restraints is frowned upon is because it has a stigma due to the way it has been used in movies, stories, and in the real world by individuals who are not trained. Restraint itself does not always include or mean the forceful physical hold of a child, and or seclusion does not always entail isolating a child in a room. Restraints have such a negative connotation that society perceives it as forcefully physically holding or using straps to hold an individual down against their will. According to a journal article by Clark and Elford, there is a lot of variety towards what restraints really means, such as stopping a person from doing something they appear to want to do, use force to make someone do something that they are resisting, restrict a person's free will of movement, and anything that stops somebody from doing something. With that being said, the definitions given cover a variety of actions taken every day by registered behavior technicians, behavior analysts, etc. Restraints can include response blocking an individual from self-injurious behaviors and even blocking an individual from throwing objects. Also, restraints can include using a leg strap to buckle an individual with learning or developmental disabilities to a wheelchair to prevent harm. For example, the leg strap is used to prevent the individual from falling off the wheelchair and getting hurt. These examples fall under the definition explored by Clark and Elford, stopping a person from doing something they appear to want to do, or restricting a person's free will of movement. Actions almost every day without realizing we are using restraints ourselves. If society is heavily against restraints, then my question is, should we let individuals perform self-injurious behaviors and throw objects such as tables and chairs, since response blocking falls under restricting an individual from doing something they want to do? Or should we let individuals with learning or developmental disabilities fall off their wheelchair and get hurt, since using a leg strap is perceived as restricting a person's free will of movement? Another point I want to mention is that there are occasions during applied behavior analysis services where the therapist may tell a child to sit down or perform some type of action, but the child refuses. As a result, the therapist may have to fully or partially physically prompt the child to sit down or perform the action given, since it was a demand. Based on the definitions given by Clark and Elford, this example falls under making someone do something that they are resisting against. Once again, should we let children disregard our demands since making them do it is a restraint? As I mentioned earlier, restraint itself does not only cover forcefully strapping or holding an individual down. It can have various definitions. As far as seclusion is frowned upon as the use of a timeout room or leaving an individual alone in a dark, empty room. However, there are different forms of seclusions used, such as a partition timeout, where the client remains in the setting, but the view is blocked by a wall or partition, and non-exclusionary timeout, where the client remains in the setting, but reinforcement is unavailable. In both instances, the individual is isolated from peers, but not in an empty, dark room. It is important for society to be informed of the different meanings of restraints and seclusion and the different actions both terms may cover. And now we're going to go talk about the legislation towards restraints and seclusion. So next up is Corinne.
Unfortunately, the lack of defining restraints across all environments and services has a big impact on the stigma restraints already has. The actions some services may take may be viewed as restraints by other services and vice versa, as quoted on the journal article by Clark and Elford. The range of circumstances under which something is considered to be a restraint will vary depending on the definition adopted. As of now, many different services have offered different definitions of what restraint means. This causes confusion for many families that may not just use one type of service, but a variety of services as well. A client can have a type of protocol being done in environment A, which is not defined as a restraint there, but in environment B, that protocol may be defined as a restraint. Imagine how confusing this can be to families. As a result, I believe legislation should come up with one general definition of restraints and include what actions it covers. This would minimize the negative connotations restraint already has and minimize the confusion for families. Also, the term of legislation can term restraint with another word or phrase. The term itself has such stigma that it may be time to choose a different term for all services across the United States to use. Just as how important it is to give the term restraints a specific and general definition for everyone to use, the criteria for its use is important as well. So when we talk about the criteria for the use of restraints and seclusion, we're referring to the behavior that the client is engaging in and at what extent should it be addressed using restraints or seclusions. There should always be clarification stating at what point these strategies are used. For example, if a client throws a pencil, but the behavior does not escalate beyond that point, there's truly not a need for a use of a restraint or seclusion. And if restraints and seclusions are to be used with a client, this procedure should be used or should be stated clearly in the client's behavior guidelines. This should include the length of time that the client is engaged in the behavior or the magnitude that the behavior has to reach before implementing these strategies. The behavior guidelines should also state at what point the procedure should be ended. So if we use the example of using the focus room for a client that's engaging in behavior, you could develop a criteria that that client must be calm for, say, 1 entire minute before they can, before the procedure should be ended. And this criteria should be based on the history of the behavior. So what did the behavior look like in the past? And how can we use that information that we've already collected to keep ourselves and our clients safe? When we include this vital information into our behavior guidelines, we decrease the probability that restraints and seclusions will be used unethically and excessively. Kelsey, do you have anything else to add?
For consent, back to kind of what you've already touched on, there must be sign-off. So back to code 4.04, just briefly touching on that, it is approving behavior change programs. So they must obtain the client's written approval of the behavior change program before implementation or making significant modifications. We already kind of touched on 4.08, but just again, before implementing punishment-based procedures, behavior analysts must ensure that the appropriate steps have been taken to implement reinforcement-based procedures unless the severity or dangerousness of the behavior necessitates immediate use of an aversive procedure. 9.03 is also back to informed consent. So behavior analysts inform participants or their guardian in understandable language about the nature of research and implementation, and the willingness to participate. So moving on from consent.
So how exactly can we fix the issue? Legislation should most definitely come up with one general definition for restraints, and that should include what actions it covers. They should also term restraints with another word or phrase, and it is important, once again, to give the term restraints a specific and general definition for everyone to use, so that we kind of take away that confusion in families and across the team of the client.
Okay, so great job, guys. Now let's ask some questions. So first question, is the use of restraints and seclusions ethical?
Speaking on behalf of the con site, we stated previously that the Ethical Code 4.09 said that BCBAs must make considerations regarding punishment procedures and the least restrictive measures possible. Research has shown that these alternative measures are effective, and therefore the use of restraints and seclusion would violate this code.
Speaking on the pro side of our restraints ethical, I can also go back to code 4.08. So before implementing any punishment-based procedures, we have to ensure appropriate steps. We must evaluate the effectiveness of the procedures and modify the behavior change program if it isn't effective. We will also always discontinue the use of aversive procedures when they're no longer needed. So I think it is ethical.
Awesome. Great job, guys. Okay, number 2. What role should a behavior analyst play in interventions involving restraints and seclusions?
I think we can all agree that behavior analysts should play a large role in every part of planning an intervention for a restraint and seclusion. We should be present for the role of communicating amongst the team, amongst the parents, amongst the teachers, amongst all individuals, and gaining the consent of the clients. We should also be present for training staff. We should also be present for writing the protocol for the restraint and its use and removal. So in summation, the behavior analyst should be part of every part of the process.
Awesome, Corinne. Now, is there any situation in which the con side would feel it appropriate to include a seclusion or restraint during treatment?
I would say that there are instances in which it's appropriate to use seclusion and restraint, but like we've stated before, I would only suggest using these if every other method has already been attempted. We definitely want to try positive reinforcement first. We'd also like to implement some different responses that the client could engage in that serve the same function as the unwanted behavior that would cause for the need for a restraint and seclusion. And once all of those interventions have been attempted, if and only if they all fail in decreasing the behavior or replacing it with a more appropriate one, then we would go in using a restraint and seclusion. And even then, we want to use a restraint that is going to be least restrictive on our clients.
Thank you for your response, Oshi. Teachers have many children in their class. How are they supposed to respond to a child throwing toys and hurting other children during one of his tantrums?
That's actually a very good question. From personal experience, I've seen it firsthand how teachers react when one of the kids in the classroom, throws a toy or decides to hurt another student. Fortunately, from what I've witnessed, a lot of the teachers, just do the best they can. They try to response block. They try to redirect the student to do something else, to just kind of minimize the problem behavior. But I think this actually stems to, now this is where I feel that teachers and any professional that works with kids, in a school or in a special ed class or anywhere where there might be a chance for problem behavior, they should include some type of training where a behavior analyst is the one actually training them with certain protocols, even certain restraints to do in case these situations do happen. So I do feel that, unfortunately, a lot of teachers do face this challenge, and I feel that that's where the training should come in more, and these professionals should get, the help and training that they need in order to, whenever these situations happen, they know what to do and how to react to prevent any problem behavior that may escalate.
Great. Thank you for your thoughts, Fresha. So last question. When using seclusion, how long do you seclude a client? How do you determine the criteria for the child to be released from the seclusion?
When you use seclusion with a client, I think it's really important to just assess the behavior as it's happening when you're trying to determine how long that child should be secluded. I really like the example of the focus room where it's a empty room that's padded so the client can't cause a bunch of harm to themselves, but there's also a camera present so that the BCBA and the therapist can still observe the learner's behavior. In instances where you are using seclusion, I think that the client should be secluded until they are calm or at a state where they no longer pose a risk to themselves or others. As far as determining the criteria for when they should be released, I think it's really important to look at the history of the behavior. So say a learner has been calm for 30 seconds, but that learner has a history of re-escalating within 30 seconds of a behavior, then I don't think that that's something that you could truly call calm. So you really need to look at the history of the behavior, how long is in their history of being calm before the behavior is truly over, before we know that if we end the procedure that the behavior will not re-escalate. So yeah, I really think that just looking at the history of the behavior and putting that in the behavior guidelines, so anyone that may be implementing a seclusion on a client understands the criteria for which you would end that procedure.
Awesome. Well, thank you all for your thoughts on these questions and throughout the debate. And that concludes our debate.